think of the serum hormone test. Think of those as testing, again, analogy back to the organic machine analogy. You're testing what is actually in the engine, what is the fuel like, how are things in vivo. And then the saliva and the urine is more like testing what comes out of the exhaust and what comes out of the hood of the car, if you will. It tells you a ton about the car. But I know when you hook up a car, you'll like test the exhaust and like dyno and horsepower and this and that. So it is very helpful, but I like to use all in concert. In the right context, they can be exceedingly helpful.
Hello and welcome back to the Vibrant Wellness Podcast. I'm your host, Dr. Emmie Brown. Today, I'm excited to welcome Dr. Kyle Gillett. Dr. Gillett is the founder of Gillett Health with clinics in Newport Beach, California, and Kansas City, Kansas. He enjoys providing holistic, individualized care to his patients, and his practice includes preventive medicine, aesthetics, sports medicine, hormone optimization, and precision medicine, including genomics. On this episode, we'll discuss Dr. Gillett's approach to individualized and evidence-based longevity health plans with a focus on his expertise in hormone and peptide therapies and related need-to-know laboratory testing insights. I'm excited to get into it with Dr. Gillett. Thank you so much for being here.
My pleasure. Thank you.
Yeah, of course. I'm wondering about the biggest misunderstanding, or maybe there's a few of them around hormone therapy today, especially in the anti-aging space. And you mentioned in our prep for today that, calling anti-aging practices just that may be a little bit, I don't know. I don't want to speak for you. Maybe it's a little bit of a issue based on where we should be heading, and maybe we should be focusing on a different perspective. So I'd love to hear your take on this, maybe some misunderstandings in this space.
Yeah, I'll answer the question about hormone misconceptions first. So one of the big ones is people argue back and forth with societies like ACOG and AACE, which is the OB-GYNs and the endocrinologist societies. And there's this disagreement on bioidentical versus synthetic hormones, but there's actually 4 different classes. So you can have bioidentical hormones that come from a plant and that are slightly altered. For example, a lot of commercial products come from yams, and you can make testosterone or estrogen from yams or even from soy. But you can have a bioidentical product that is synthetic and that is not synthetic. So it can be bioidentical and synthetic. And then you can have a non-bioidentical that is actually naturally occurring. It's just not bioidentical in humans. So, if you read a statement from the ACOG organization that says, there's no great evidence that bioidentical hormones are better, it's a little bit misleading, probably not purposely, just because what they're trying to say is compounded hormones. So when you see someone saying they're like for or against bioidenticals, I don't actually think most societies are against bioidentical hormones. They're just trying to say, why would you use compounded hormones if there is a commercial product that is similar? I don't want to get into like specifics, and like obviously some have dyes in them and some have don't and inert ingredients, but that's just a big concept. And then, I guess the second part of the question would be, people don't like this anti-aging term, but the general population understands it. It reminds me of when there was this big hullabaloo about how when people would call LDL cholesterol, and then people would say, well, LDL is not cholesterol, it's a lipoprotein. It's like, okay, technically true. But when you talk to the population on podcasts, maybe they want you to say LDL cholesterol because that's what they understand. They might not know what ApoB is. And it's kind of the same thing with anti-aging. If you're talking about, a longevity protocol or a wellness protocol, I'm not against saying, this is an anti-aging intervention. But, for people who like to get into the specifics, there's a difference between cosmetic anti-aging, functional anti-aging, what you're able to do. That's your activities of living, and beyond that, going on hikes when you're 100 years old. And then there's a difference between cellular anti-aging, mitochondrial anti-aging. There's a lot of different categories.
Right. Yes. And so when you said calling everything anti-aging, right? We're just oversimplifying is how I interpreted that statement of yours.
Mhm.
There's a lot more nuance there, is what I'm hearing.
Yeah, yeah, and even among this is something that I've seen trending on TikTok, and my TikTok's about peptides trends too. So I think there's such a thing as benevolent clickbait, where you're trying to teach a concept, whereas if it's just pure clickbait and there's no actual good information behind it, then maybe that's not ideal. But top anti-aging or even top longevity peptides, and then one of them is a growth hormone releasing peptide, whether it's tesamorelin or whatever it is. And that's going to be great from a injury standpoint, and even like a body composition standpoint, and probably a cosmetic standpoint. But at the cellular level, it's actually increasing cell turnover. Same thing for HGH. People did a lot more back in the 90s. Perhaps at a DNA level, because you're turning over your cells more often, then that could lead to telomere shortening and like less cellular age, if that makes sense. So some good longevity interventions are not good in other areas of longevity.
Well said. Okay, yes. So it does sound like there's simplification, excuse me, with a lot of these concepts. And that's why we need experts like you on podcasts like this to explain that there's an artistry and a science behind all of this. And it really takes skill to figure it out.
And I'm just simplifying. I'm not trying to oversimplify, but simplifying the oversimplification.
Right. Well, we need to start there too, when we're just learning, I feel, right? Starting with the meat of the matter, if you will, as you said.
Yeah. Yeah. I think a lot of people come in to these services, of which I obviously have one, as you mentioned, and they want to order good comprehensive lab panels, which makes a lot of sense. And you go to the mechanic and they're going to do like a full scope of, well, they should. A good mechanic, if you like your car, they're going to do a full scope of that. And with our organic machines, which are our bodies, we should do the same thing. But when you go to the mechanic, you tell them in very simple terms, I want my car to be fast and to look good and make sure it doesn't break down. Mm-hmm. But when we go to these other places, you say, well, I want my, health grade, of which I have one, so I'm not against them, or age clock, or this or that, or my aging velocity. I want this to be better. But what do you actually want? I think we should be able to, before we get these panels ordered on intake, which I'm a fan of, at least to be able to have a goal.
Right. Yes. And that is a good segue into what does your intake process look like? Because I'm always fascinated with functional medicine practices. And I just imagine, there could be pages on an iPad or what have you. Maybe it's physical form, pages of intake, or are you getting a lot of that in office? And what are you asking that might be surprising to other providers?
First question is top 3 goals. And then I also do have an executive physical program, which is a little cookie cutter. A lot of times I make fun of cookie cutter clinics that are pure cookie cutter, just to, constructively say, hey, let's critically think about this. But top 3 goals, and then actually a very traditional history and physical. So like HPI, if there's a chief complaint, review of systems, family history, social history, their past medical history, their surgical history, their habits, all of the 7 lifestyle pillars. And then there's 4 questions about the executive physical program track that I put them along. So body composition track, body composition and aesthetics, cardiometabolic health, cancer detection and prevention, and ASCVD. So those are like the 4 tracks they choose from, and there's pertinent questions. I look over the form, and it actually doesn't take that long to look over. And then I order their intake labs, which often do look pretty similar, but they're not identical for every single person doing the program, if you will. And some people do more of like a gut health track, and some people do more of a cognitive health track that's not listed as like one of the cookie cutter 4 track options. But it's very quick to look over those goals and then order the pertinent labs.
Mm-hmm. And I saw in your clinic site, Gillett Health, I like your laboratory services page where you do have combinations here. And I imagine you can customize these further. So, for example, to give listeners an idea, you have an athlete panel, male, female. You have the bare bones, the bare minimum cardiovascular panel. I like this, $50. Who can argue
Yeah.
with that? But then the heart health add-on, $155. Lipoprotein A, 15. So I love that you have these options and you're defining what's in these panels. Are you adding or subtracting based on certain cases too? I'm wondering.
Yeah, certainly so. A lot of people would benefit from a more specialty lab. There's different tests that do have false positives, like a early cancer detection and prevention test. And for that panel, I make sure that I actually, have a communication with the patient about the potential upsides and downsides in their specific case with their risk factors. It's called pre-test probability. Basically, the probability of a false positive versus a false negative, and what harm could come from both, actually, because both can be, you don't want to have someone think, oh, I got my cancer detection test and it was negative, so that for sure I don't have it, when there's still a 50% chance that they could have it. So that's just one example. But as you mentioned, I am working on that project, and Sage Bio does a great job of that. We have our 2 different AIs that we're working on, as everybody's working on some sort of AI. But, I'm training it on, the podcast that we do and the cases that we go over in our weekly provider meetings with the other clinicians at Gillett Health. So I think that helps. But what I found particularly interesting, I was actually giving a talk about 2 months ago at a conference for longevity doctors, and I asked the audience, classically we're trained in med school to do a full history and physical before ordering any lab, including the exam. And there's a lot of evidence that, that obviously at some point you want to do that. But I asked people how many of them order labs before actually seeing the patient. And only a couple of them, including myself, raised our hands. So I thought that was interesting, because I've always thought it's kind of like playing Little League. You get so much information with getting a good, comprehensive lab panel. And like I said, you can still target it, but the patient likes that because it saves them time, because otherwise it's kind of like a social visit, which can help, especially for pediatric patients. You want a ton of social visits. But for most patients, they're extremely happy to do that. So I would like to help normalize that.
Right. Kind of getting that data up front. And at this point, I do want to jump into hormones a little bit more. I think listeners out there, a lot of our listeners are healthcare practitioners, but also just health-minded people. And we're hearing more and more about hormone replacement, but we also need to do a good intake, understand what needs to be tested first, as we just mentioned. So there's different types of hormone testing: serum versus salivary versus urine. How do we decide? Can we break it down for people out there who might not be specialized in this?
Yeah. So think of the serum hormone test, and also I would say, like RBC tests and et cetera, intracellular tests. Think of those as testing, again, analogy back to the organic machine analogy. You're testing what is actually in the engine, what is the fuel like, how are things in vivo. And then the saliva and the urine is more like testing what comes out of the exhaust and what comes out of the hood of the car, if you will. It's been used, of course, it's not going to be used again. It tells you a ton about the car. So, when you hook up and I'm not a car person, by the way, oddly enough, but I know when you hook up a car, you'll test the exhaust and dyno and horsepower and this and that. So it is very helpful, but I like to use all in concert. I very seldom order only urine tests. But to start out, I think that a lot of people, and I do have some patients that don't like getting blood drawn, and yes, there's other options and this and that, but I do like traditional phlebotomy blood draw tests in concert with other specialty tests. I think it's very helpful. But that's how I think of it, because when you talk to conventional medicine, other than maybe a salivary cortisol or a few other exceptions, urine metanephrines, whatever else, they're very skeptical of those specialty tests. But in the right context, they can be exceedingly helpful.
I agree. And I know why, but I'd love to hear it from you, Dr. Gillett. As far as, let's start with the urinary hormones. And remind me again the analogy. I think you said the saliva was like the exhaust, although I think I would think about urine as kind of like the exhaust.
Urine's the exhaust. Yeah, the saliva is like what comes out of the hood. Like if your hood is smoking, I guess.
Okay.
You're burning oil and you can smell it. So, it's not a perfect analogy, but yeah, especially so I guess specifically with sex hormones, estrogens and androgens are actually metabolized pretty similarly, not exactly, but they can be metabolized via a few different ways. Glucuronidation, that's why, people are interested. One of the reasons you're interested in beta glucuronidase enzyme, for example, in the stool, but they can be excreted via stool significantly and urine significantly. And estrogens can be hydroxylated in the liver. They can have a sulfate group attached. So sulfurtransferase will do that. They can have a ubiquitin group attached, which is ubiquitination. Both in the urine and the stool, they can have a glucuronidase group attached via glucuronidation. And then if that is cleaved, then they can recirculate, at least in the stool, but not in the urine. People are familiar with various tests for estrogen and progesterone metabolites in the urine, both clinical tests and like the daily test strips that test things like E3G, which is estrone 3 glucuronidated estrone, basically, and PDG. But if you're trying to figure out what your enzymatic activity, for example, 5-alpha reductase is like very low-hanging fruit, you can look at both 5-alpha reduced progesterone and 5-alpha reduced testosterone. So the ratio of both of those in the urine can tell you, one, like how is your 5-alpha reductase inhibitor working for both those molecules? And also you can get a proxy estimate of how are your progestogenic neurosteroids doing. For those who don't know, that's just, they bind the GABA receptor. They can either activate it or inactivate it. I actually think of it as reverse T3 and T3. So that's your allopregnanolone and your isoallopregnanolone. Is it activating GABA or is it inactivating GABA? So is it causing, like anxiousness, agitation, et cetera?
And you can't get that on serum, correct? And that's the utility there for urine.
Correct. Currently, to my knowledge, that is actually not available on serum. And I think the urine is a great proxy for that. And, it's very helpful to get that along with other enzymes that are in the urine. And then, if you're metabolizing something more or less through the urine, you might be metabolizing that more through the stool. So it doesn't necessarily mean you're but you can get a decent idea if you're a fast or slow metabolizer. The other thing is, I do like to measure SHBG. For those who don't know, that's sex hormone binding globulin, because in general, if that's very high, you're actually going to have less free hormones in general to metabolize through your kidneys and also via the liver.
Right. Yes. And you mentioned route of, I think it was it testosterone I saw on your site, kind of just an example of being mindful of what preparation or route we're using for HRT depending on labs. And that's the artistry, right? That's the really big skill that we need to look for in practitioners who know what they're doing with HRT. So I'm glad that you're bringing that up because there's a lot to this. So to your point, and you can speak to that a little bit more clearly. I read it very quickly. I think it was topical testosterone and, what was it? It was with low sex hormone binding globulin, right? That there's something there that you wanted to be careful about.
Definitely. Yeah, that's true. So, there's a lot of advantages and disadvantages to various routes. One of the advantages to topical testosterone, gels and creams, is that it does not lower that SHBG. So you don't have that fast metabolism, lots of peaks and troughs. And in general, especially for females, you don't want too low of an SHBG because it can lead to virilization, which is basically masculinization symptoms. And then in some rare cases, depending on what the individual provider sees, and I wish this is something that more specialists were cognizant of. If you have, let's say, someone with delayed puberty or delayed development of secondary sexual characteristics, you probably want sky-high 5-alpha reduction and you want low SHBG. So you might want a scrotally applied topical testosterone with very high conversion to DHT. And you also might want to keep SHBG low at the same time. So using things like lymphatically absorbed testosterone, which is testosterone undecanoate capsules, can be very helpful. Now, that's obviously relatively rare cases, and zebras in medicine are just rare conditions. They tend to kind of like flock together to the same healthcare providers and clinicians. But the concepts can be helpful for anyone. I would say especially females, even more so than males, because there's such a variability in androgen sensitivity and estrogen sensitivity.
And that's just one example. So I can only imagine, how many different scenarios you are tasked with figuring out. And that's why we don't want cookie cutter protocols. And, hormones can be a whole episode, but I do want to touch on peptides a little bit too. So speaking to peptides, what is kind of a panel or an example of a panel of laboratory tests that you're doing before considering peptide therapies?
Definitely an IGF-1, which is insulin-like growth factor 1. I think of IGF-1 as insulin plus growth hormone makes your IGF-1. And if it's really low, then you probably are going to have some delayed healing. IGF-1 and growth hormone both have benefit in that regard. And many peptides can increase IGF-1, which can be good. It can also be bad if it's too high, because it can also make you more likely to have prediabetes or insulin resistance, or even a reversible diabetic-like state. If you Google ghrelin agonist or growth hormone peptide, there's actually several case reports of people developing A1Cs above 6.5, a temporary diabetes state that improved after they came off. More like gestational diabetes than actual diabetes. But I also like to do both labs and diagnostics and any appropriate cancer screening. And if the patient is a good candidate, cancer detection and prevention as early as possible, just in case there might be a tumor. I think that things, even like semaglutide, that increase growth hormone a lot, probably do grow those tumors a little faster if you happen to have them, but I don't think that it causes it. So I kind of do the aggressive preventive medicine and maintenance, if you will. Make sure that organic machine is rock solid, and then optimize from there.
And I just don't, at least I'm not hearing the safety conversation enough surrounding peptides. And maybe I'm just not listening to the particular podcasts or, reading those particular articles. But, in the functional medicine space, I just think we have to be extra safe in terms of, like you said, making sure that there's no pathology to start with, and monitoring anything that might be risky or suspicious before starting these therapies. So I can appreciate that. And I'm kind of curious also, how do you use these peptides for longevity, or which ones are you using? I think that's an area that we're interested in here at Vibrant. So, we won't say anti-aging, but let's try to increase the quality of our lifespan, right, for as long as we can. And so what peptides are you using, and maybe what are some side effects or contraindications there?
Yeah, some of my favorites, of course, insulin would be the top of the list because it makes diabetics live much longer. GLP-1s, of course, are at the top of the list too. Any incretin, but yeah, insulin, that's the OG peptide, in my opinion.
Yeah.
Really helps. It's life-saving for all the, when it was first found, we had almost all type 1 diabetics. We didn't really have type 2 diabetics, 70 years ago, whenever it was. But anyways, not to belabor that point, I do like the growth hormone secretagogue peptides, not just the GLP-1s and incretins, but also the ghrelin agonists and GHRH analogs like tesamorelin, CJC, and sermorelin. I also like BPC 157. I've done a lot of podcasts on that and kind of like why I think it's reasonable to use clinically at this point, and lots of other people have. But for short periods of time, given that it does increase VEGF, and it's kind of the opposite of Avastin. And then kind of like the dark horse of ones that not as many people are familiar with, GHK cover peptide, but in an injectable form, because usually it's just used topically, I think is interesting, especially in older populations. I think amylin analogs are also very interesting, like cagrilinotide or pramlintide. Especially cagrilinotide, I think is going to be massive. Myostatin inhibitors are not peptides. HCG is not peptides, but it's not a peptide. I do like it though. And then calcitonin is a little known peptide that I think has a lot of utility in people with suboptimal bone density and lower calcium levels that are kind of like vitamin D resistant, if you will.
Interesting. And what I'm hearing, and I am really just learning the basics along with listeners out there. I'm right there with you learning the basics of peptides. It sounds like it should be thought of as icing, right? Like we need the cake. We need to have a solid foundation of all the things that I mentioned in the beginning, the 7 pillars, right? Our sleep, our social life, our diet, right? This is extremely important. And then peptides are kind of the icing. Is that how you think about it?
Yeah, or a tool to help those things work better.
Mm-hmm.
You're already doing the work. The lifestyle is the work, so you're doing that, and then it's a tool on top of that to augment the success.
Right. Yeah. Well, and I'm sure I've heard this too before that if you, I don't know, you have someone who's coming to you, I'm sure this is, it can take a while for somebody to really dial in those foundations. The peptides aren't going to work as well unless you have those fundamental pieces in place, right?
Certainly. The lifestyle interventions are more powerful than any medication, supplement, or peptide.
We said that already, right?
Mm-hmm. Yep.
Exactly. Yes. Thanks to you. We already mentioned that. Yeah. So that work up front is extremely important. I think that's a really poignant piece here to emphasize. So with that, this is just jam packed already, Dr. Gillett. I do want to move on and speak to cognitive resilience a little bit in brain health, because you also help patients optimize neurologically speaking, and from a neurocognitive standpoint. And you have 3 little ones under the age of 5. Is that correct?
Yes, I have 3 young children.
Yes. And you mentioned in preparation for this, and I always want to know, what do you do? If you don't mind sharing, I'm always interested to hear, what are you doing? Hopefully, you're practicing what you preach to some extent. Of course, we all have individualized needs, but what are you doing in this regard to stay sharp?
Yeah.
Being a father.
Some people are familiar with the 80-20 rule for diet. 80% good whole foods, nutritious, and then 20% dietary flexibility, where maybe things are not as natural. And I basically try to apply that rule to the other areas of my life and then plan ahead so that I can be consistently good, at least in this season of my life, rather than, be optimal taking things from 100% to 110%, which can be done. But, if my sleep is terrible, then I'm not against utilizing something like even a Ramelteon, which is like a prescription melatonin receptor agonist that binds the first 2 receptors, and many other things. So it goes throughout the whole lifestyle pillars. I try to be consistently socially healthy and spiritually healthy, and I'm checking a lot of these boxes at the same time. So my friends at the gym, which I go, pretty much every morning, even if I'm just doing mobility, it just gets me in the habit. Maybe I'm just doing some very easy cardiovascular exercise, keep my mind a bit calmer during the day. I think that there's a lot of merit to that. But personally, I do like to stack these different activities together. So a normal day for me would be wake up around 5, go to either the regular gym, which is Lifetime, or the CrossFit gym. And after that, go to work until, maybe 4 p.m. or 6 p.m. And then after that, go home, spend time with the family, don't do any work-related activities, and then check off a lot of those other lifestyle pillars at that time.
Pretty straightforward. Make it sound easy.
Yeah. And there's always speed bumps that come up. Sometimes people say, wow, you look like you didn't sleep at all, or like you went to the club last night, or my favorite is, you look like you have been smoking some herb, if that makes sense. And, sometimes you're just tired and your sleep's not good because one or more kids have been up all night, and that happens. And that's why I really respect people like Thomas DeLauer or Nick Bear. They both have also very young children, but they're both very naturally minded, and they practice what they preach. And sometimes they look a little bit tired or worn down or whatnot. but they're very resilient, and they get right back on the good lifestyle habits rather than veering off when it's kind of most easy to do so.
Right. Yeah, it's a marathon, not a sprint. This thing we call health and wellness, and like you said, speed bumps along the way. And you said very easy cardio at one point, Dr. Gillette, and I'm wondering what is that? What is that for you?
Oh,
It's
great
very
question.
subjective.
Yeah, this has actually been a super common question recently. I like something called the arc trainer. It's not an elliptical that goes in an ellipse, but it's an arc trainer that goes in an arc. And a lot of times after like a CrossFit Metcon or whatnot, my heart rate might be 120 from doing EMOMs, which is every minute on the minute lifts. It's very high yield. It's very time efficient. And I try not to ego lift. So that's sometimes Metcons are pretty easy cardio. But, my heart rate's probably below 150, and I can usually talk through it relatively easily. But yes, I do love the bike and the stair stepper and the Cybex arc trainer. I'm not sponsored by them, unfortunately, I guess. But I'll get on my phone and do emails or meditate or pray when I do so.
Okay, I like that. Now that we're on the topic of training, and I know that you treat athletes, I'm just curious what's coming out, what's kind of exciting as far as research and longevity concerning exercise at this point, in your opinion?
Yeah, a great question. Creatine in kids and pregnant ladies, I think, is
Oh,
the research is finally catching up to honestly what we already knew. So that's great. I think it's very interesting to look at things like, people are interested in these prescription myostatin inhibitors, which I think will be clinically useful, but there's a downside to everything. We don't know the downside yet, so that's pretty scary. But bodybuilders used to use a myostatin inhibitor called YK11. Basically, it turns off the signal that turns off muscle growth, thereby permitting
oh,
huge
wow.
amounts of muscle growth and fat loss. And the early stage clinical trials, the phase 2s and earlier, look really good. But there's obviously going to be a downside at some point. And, for kids who need to have a stronger diaphragm, I think they'll be very reasonable. But a lot of athletes are, of course, thinking, when can I get this? It's an IV infusion, so it's more difficult for a compounding pharmacy to make. See, a lot of athletes are definitely looking for this, or how can they get these gene therapies? But what's exciting to me is things like fortotropin, and maybe that is a safer way, or epicatechin, a safer way to get some myostatin inhibition without taking these newer risk unknown medications. In the future, of course, they're very exciting.
Interesting. And what about as far as the training component? I'm sure that there are some interesting training protocols that go along with the testing of these medications.
Yeah, great question. So one of the big trends recently is this quote unquote hybrid athlete trend, which I guess I kind of do. I've always done lots of running and lifting weights, at least the last 15 years or so. And I think it's interesting that you're seeing better outcomes when you split up your very hard days. So if I'm doing a resistance day or a strength day, and the athletes that I see, if they're stagnating in this strength area, then you do have to emphasize that. If they're stagnating in terms of their cardio and running, then you do have to emphasize that and do that on your hard day. So right now, probably going to do another high rocks in 6 months, which is just a bunch of running and a few workouts. All together, no break. I'm almost exclusively doing my hardest workouts on my run and hard cardio days, but no more than about 2 per week. So it used to be that there's periodized training and, would emphasize progressive overload, which you still should to some degree. But now I think splitting up your days to strength emphasis days and cardio emphasis days, and then maybe tacking on a little bit of the other at the end, but very easy, is going to get you a good bang for the buck. And then, of course, in running, threshold and dual threshold days, and the Norwegian 4x4 method, which probably talked about in the podcast before. That's super popular among endurance athletes.
Mm-hmm. Okay. Yeah, I've been following Dr. Stacy Sims recently. Really like her content in regard to research in women for exercise physiology. I don't think that we have enough of that research, of course, right, when it comes to women. But it's always fascinating to hear about why should my workout look like this? Why should I design it this way? And you're saying primarily keep strength on strength days, keep cardio on cardio days, but mix maybe a little bit, just go easy on the other one. And only maybe pick 2 of those intense days a week.
Yeah. And I think that is, that can be applied across many disciplines. So even if you're a track and field athlete, maybe you throw the discus, or if you're a American football player, or even if you're, a hybrid athlete or a triathlete, then there's still a lot of benefits to strength training. And most pro athletes are even doing a lot of strength training. They do mostly sport specific hard exercises, but there's a lot of resilience that you get with that. I recently posted a podcast with the sports dietitian I've worked with for almost 4 years now. Her name's Diana, and she spoke at a lot of various conferences. I don't think she has yours yet, but anyways, we talk a lot about training as a female athlete. She is very athletic as well. My wife is too. And they talk about the differences just with their training and other females and other males. For example, my wife is just naturally very strong. She's always good at the javelin, the discus. She's always been able to, lift very heavy amounts of weight, whether it's, clean and power cleans or Olympic lifts or deadlifts or whatever else, just very heavy. And she's very explosive. So she actually rode a world record time for the 500-meter row. If someone knows what that is, it's a concept to row erg. But, certainly if she's redlining herself with running all the time, her performance and everything else is going to dip significantly. And, that's not always she can redline herself with lifting weights pretty easily. But her body composition is, more along the lines of maybe a male. So, around 15% body fat and around 200 pounds and 6 foot or a little bit over. So her muscular adaptation is going to be different than like another female athlete that might weigh half as much. So these individual to individual training differences are particularly interesting to us.
Mm-hmm. Absolutely. Yeah. I'm glad you brought that up. And that again could be another episode in terms of the sports medicine piece there. But as we're coming up on time quickly, I'd love to hear a case, maybe a case that's at the top of your mind, Dr. Gillett, concerning HRT and or peptide therapies. Maybe throw in a little bit of laboratory need to knows there, if you don't mind.
Yeah, definitely. So, lots of interesting cases that I could talk about. But one of the ones that actually went over today is a very active and healthy female. And she is in her, I'd say, early 50s, surgically menopausal for a while, but particularly active and healthy through her life. She was actually an athletic trainer for a while. So certainly knows what to do and knows about the whole food diet, and had been relatively dialed in lifestyle wise. But for a while she was kind of stagnant and just things were not as good. And one of the interesting things in this case was the discussion about can you tell, and can your significant other tell what your hormone levels are from day to day? So there's a trend called physiologic HRT or cyclical HRT, which some people might be familiar with. And in general, I'm not against it or for it, but I think it's more useful when you're a little bit younger and maybe less useful as age progresses for several reasons. But with her, she had very good biofeedback, which is, I think a benefit, but also you notice the changes more. But having slightly higher and slightly lower hormone levels, a combination of topicals and injectables and troches, and actually injectable estrogen, in her case, led to much better results in terms of the subjective feedback in that area, and the labs made sense along with it too. So, I think a lot of people that are able to tell more, I think it is possible. I don't think she thought that it was possible to get back to that type of cyclic pheromonal input, if you will. And, there's some science on it, not a ton, but I think that that was a particularly reassuring case.
Interesting. Is that similar to the Wiley protocol? Are you familiar with that? HRT protocol to basically get, I think the goal is to bring back menstruation in postmenopausal women.
Yeah, so her protocol was quite a bit different. There was not near as much of a fluctuation, and there was actually no significant change in her progesterone, just the pregnenolone, which is kind of a form of progesterone that was on.
Mm-hmm.
And yeah, the change in estradiol was just between like the max dose and then the minimum dose was 75% of it. So there was no complete withdrawal from estradiol and no complete withdrawal from progesterone either, actually. But there is a relative change. I think that especially if you go through earlier menopause or surgical menopause, which is usually earlier, or even semi-surgical menopause where they take one ovary. Like, don't tell me that you can take one ovary and then there's not going to be any difference in the ovarian output of that hormone.
Right.
But I do think that there's benefit, for example, in glandular breast tissue to go through areas of slightly more estrogenic signaling and then times of less estrogenic signaling, which could compose of just not just slightly lower estrogen, but either more progesterone or more androgen, which decreases estrogen receptor gene activation. So if your testosterone's higher during that time, you're getting less bang for your buck estrogen, if that makes sense. So I think it does make sense to kind of give your body a chance to find those atypical cells and recycle them with your immune system.
Interesting. Obviously, there's a lot to this. It's very complex. I'm wondering, before we go, do you have any plans for maybe a training program for practitioners? Because obviously you know your stuff and there's a lot of nuance again. So curious if you have any resources for listeners out there. If you don't have a training course, what do you recommend? I know we touched on that earlier, but just like learning and maybe just speaking to compounding pharmacists, can you give us something? Because to get to this level, I think listeners want to know.
Yeah. I speak at several events yearly, several CME qualified events. I do speak at longevity docs from time to time, and I've spoken at a metabolic health summit a few times. And I plan to continue to do so. Maybe at some point there's a more official training program specifically for, this kind of individualized medicine that I described that approaches someone holistically. But I guess I would at the same time, I'd also re-emphasize the textbook because, myself and some of my friends that also speak, like I mentioned, Diana and Dr. Martin, the preventive medicine physician that I work with as well. We are just a couple voices. So you don't want to be caught in an echo chamber of dogma. You want to hear lots of voices. I love it when I hear two different opinions and they're talking things out. I think that's excellent. So, emphasize the textbook and the basic information before you listen to sources like that.
Right, and compare and contrast once you get to those trainings, I think is a important message too. So amazing, Dr. Gillett. It's been such a pleasure. Before we say goodbye, if our listeners want to find you online or connect, how can they do that? Where can we find you?
Yeah, my Instagram is Kyle Gillett MD, Gillett Health on all other platforms, including the podcast for Spotify, YouTube, etc. And I guess my websites are gilletthealth.com and sagebio.com.
Perfect. Well, for all of us out there, we've learned so much through Dr. Kyle Gillett today concerning peptides, hormone therapies, laboratory testing concerning both, and everything in between. So until next time, signing off, wishing us all vibrant health and wellness.
Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness podcast to discover the latest insights and strategies for optimal health. Join us again next week. And just a reminder, this podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.